So, good evening and a warm welcome to all the dignitaries present here. I'm Jayashree from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is education in anesthesia and critical care. So let's begin today's session, for which I would like to invite Dr. Muralidhar Kanchi sir to take over. So over to you, sir. You can proceed with the talk.
Good evening and good morning, and thank you for joining us. I'm the Dean of the Indian College of Anesthesiologists and have great privilege and honor to have you with us this afternoon. Thank you for joining us. And as you are aware, today we are celebrating the 5th anniversary of ICA webinars. ICA stands for Indian College of Anesthesiologists, and we have completed 5 years of successful conducting weekly webinars of high quality every Wednesday 7 to 9 p.m. in Indian Standard Time. And it has been a very successful journey through the last 5 years. And today we are celebrating the start of the 6th year. And I am grateful to the leadership of the Indian College of Anesthesiologists for providing this platform where so many enthusiastic young and budding anesthesiologists and practicing anesthesiologists have been benefited immensely through this delivery of high quality material through webinars, which are recorded and loaded in YouTube and available for any future reference for anybody if they would like to have a look at it at a later date. And as you may be aware, Indian College of Anesthesiology started in 2008 as a trust, as an offshoot of Indian Society of Anesthesiologists, but we are existing separately since the year 2016 because of because we had the independent existence from that time onwards. And this day we have been very well acclaimed to be academically orientated and without any political frills attached to any of the posts we hold here. With that brief introduction, it's my great pleasure and honor to invite Dr. Jayashree Sood to light the lamp, and inaugurate this today's session. We have eminent personalities from all over the world participating in today's webinar, and it's my privilege to invite the President of Indian College of Anesthesiologists, Dr. Jayashree Sood, who has been labeled as one of the topmost 5 powerful anesthesiologists in the world. That is the title she has gained deservingly well. So I would like to invite Dr. Jayashree Sood to light the lamp and then say a few words, following which we will invite Dr. Radhakrishnan, and then we will request Dr. Belani to take over and conduct the scientific proceedings. Thank you so much. Dr. Jayashree Sood, please.
Good evening and good morning, everybody. It's my proud privilege to be lighting the lamp today for this 5th anniversary of the ICA webinars. Thank you. This is called the Saraswati Vandana, where we pray to the Lord Saraswati, who is the goddess of knowledge, to ensure that we conduct our education very well. So this was the Saraswati Vandana. And with this, I welcome you all to the 5th anniversary, which is a milestone global anniversary of the webinars being conducted by the Indian College of Anesthesiologists. It's a very proud moment for us because we have been conducting these webinars regularly, consecutively, every Wednesday and throughout. So this is a very proud moment, and from now onwards, it'll be the sixth volume of the webinars that are going to start. So with this, I welcome you all. Today, of course, Education in Anesthesia and Critical Care is the title, and we have very important dignitaries who shall be, of course, moderating the show, and speakers themselves are also very, very eminent, and they are experts in their own fields. So thank you very much and welcome once again.
Thank you, Dr. Jayashree, Sood, for that encouraging words of wisdom. And it's my proud privilege to request Dr. Radhakrishnan to welcome the audience and say a few words highlighting the importance of ICA in the current world of anesthesiology in India and elsewhere. Thank you so much. Dr. Radhakrishnan is the Chief Trustee. He was the President 1 year ago, maybe a couple of years ago, but now he has become the Chief Trustee, and he is the Chief Advisor for all the activities of Indian College of Anesthesiologists. Dr. Radhakrishnan, please.
Thank you, Murali. Welcome all and good evening. This is our 5 years completion celebration. We started in 2000, and during the COVID days, as an opening to the academic world, with the most modern developments being percolated to all, when we are all almost tied up. Well, this webinar was going on very well for the last 5 years without even a single break. And probably we are achieving the first ever world unit who was conducting an academic event regularly for 5 years together. Well, we crossed that particular milestone, which was earlier being kept with an American group. Now we completed that. And as you know, or those people who don't know about us, Indian College of Anesthesiologists is an academic trust formed for uniformizing the anesthesia education and the practice standards in India. And later, we were able to percolate the news, or rather, we were able to show to all the people in the world that certain things are necessary for a standardized anesthesia practice all over the world. And we are literally achieving that. Apart from our academic webinars every week, we are excellent in conducting short-term courses in certain areas which are not that popular, like onco-anesthesia or thoracic anesthesia, or certain aspects of critical care. Like that, we are progressing with short-term training and certification of that particular course. And as I said earlier, we are an academic trust with ATG exemption and 12 AA sanction of the Government of India, and is registered through New Delhi office of the Government of India. And we are linked to ASA as well as Samba Society of America. And we regularly interact with them on academic matters. We hope this may be able to continue. And with the help of Dr. Kumar Belani, who is our international dean, we are regularly in contact with our colleagues of America as well as with the ASA organization. And now, we are now stressing on patient safety in anesthesia, as well as how we may be able to mentor our youngsters for a steady career, as well as further education. And we are proceeding and we are succeeding in that. And probably we may be able to provide more materials in the coming 1 year. Apart from running all these courses, we run publications, the Yearbook of Anesthesiology, which also again is a landmark publication in anesthesia, and it's the first one in India to have really crossed a mark of something like 13 years in publishing continuously the Yearbook of Anesthesia, which is a real treasure for every practitioner or a student. And my dear friends, we are going ahead. We are going ahead with further motives. And soon you will be hearing from us and what are our ways, how we are going to proceed. And today is our 5th year of existence, or I may say, we're going to land on the 6th year of webinars. And we wish you all the very best in anesthesia and wish you better skills and practice standards in anesthesia. Wish you all the best and thank you.
Thank you, Dr. Radhakrishnan, for that lovely address and having highlighted the importance of safety and mentoring youngsters, which is the backbone of ICA activities. Thank you so much for that wonderful address. Thank you so much. And it's my great pleasure now to start the scientific session with the introduction of Dr. Belani, Dr. Baljit Singh, and Dr. Mukul Kapoor, who are our panelists, in addition to Dr. Jayashree, Radhakrishnan, and me. So Dr. Belani, as already pointed out, is the International Dean for the Indian College of Anesthesiologists. I welcome him. And next, I would like to welcome Dr. Baljit Singh, who is the CEO of the Indian College of Anesthesiologists, again, an accomplished personality in the field of anesthesiology. When you talk about Indian topmost leaders in anesthesiologists. And then we have Dr. Mukul Kapoor. He is a very academic personality, again talented, and his writing skills are immensely popular. And thank you, Dr. Mukul Kapoor. He has served the Indian Association of Cardiothoracic Anesthesiology as the editor, and I think he's still continuing there. Thank you so much, Dr. Mukul Kapoor. And with that brief introductions, I will request Dr. Belani to take over and go on with the listed program. Thank you so much, and be with us till the end so that we can have some interesting panel discussion at the end. Thank you so much.
Good morning, and thank you, Dr. Kanchi, for introducing me, and welcome to the leadership of ICA and my co-panelists. Congratulations on completing 5 consecutive years of continuous weekly webinars. Certainly a very hard thing to achieve, but the college has done it, and it's my distinguished pleasure to be able to help the Indian College maintain anesthesia and patient safety during the surgical care of patients all over India. We will begin our scientific program now, and we will have a panel discussion at the end of the session. Our first speaker is Dr. Debnath Chatterjee, who is a pediatric anesthesiologist at the Children's Hospital in Colorado. He's professor of anesthesia there, and he has completed his MBBS from JIPMER in Pondicherry, followed by an anesthesia residency at Upstate Medical University in Syracuse, New York. He then pursued a pediatric anesthesia fellowship at Boston Children's Hospital, and he has been practicing since as a pediatric anesthesiologist since 2005. He is the former fellowship program director at the UC University of Colorado, and is now the director of the fetal anesthesia program at the Colorado Fetal Care Center. Dr. Chatterjee is very passionate about medical education, which we are going to be discussing today, and he is the editor-in-chief of OpenAnesthesia, which is an online resource used by anesthesia trainees and faculty worldwide. He is one of the founding editors of the Society for Pediatric Anesthesia Question of the Week project and the Society of Pediatric Anesthesia one-pagers. He also serves as an education editor for the journal Pediatric Anesthesia. He's the current chair of the American Academy of Pediatrics section on anesthesiology and the American Society of Anesthesiologists Committee on Pediatric Anesthesia. Welcome, Deb, and please take over.
Thank you, Dr. Belani. Are you able to hear me?
Yes.
Yes.
Perfect. All right. Thank you so much for this opportunity. It's truly an honor to be here to participate in this webinar. What I'm hoping to do over the next 10 minutes or so is give you a very brief overview of what open anesthesia is and what we are trying to achieve there. And I'd love to explore opportunities for collaboration with the Indian College of Anesthesiologists. So I do not have a PowerPoint slide deck, so I'll speak for about a couple of minutes, and then I figured I'll just share my screen and take you through the website so I can show you all the different types of resources we have there. And before I get started, I just want to make sure I get disclosures out of the way. So as far as financial disclosures go, the only conflict is that I receive a small editorial stipend from the IARS, the International Anesthesia Research Society, to be the editor-in-chief of Open Anesthesia. So what is Open Anesthesia? It's an online educational resource that's, as I mentioned, it's sponsored by the International Anesthesia Research Society. And what I would like to emphasize here is a couple of things. One is that it's open access and free, which means that all the content we have currently on Open Anesthesia is free, it's open access. You have to register to access the content, but we purely do that to get an idea of who our users are. Number two is that all the content on our website is peer reviewed, and we try to focus on getting high quality educational content. And number three is like collaboration is a big part of what we do. Instead of trying to reinvent the wheel, we have an entire section of a website called External Resources, where we share content that are created by our collaborators. So with that, I also want to share some statistics of what Open Anesthesia, like as far as the usage goes. So as I mentioned earlier, it's sponsored by the IARS, and it's the official e-learning platform of the IARS, just like the journal Anesthesia and Analgesia is the official journal of the IARS. The Open Anesthesia is the official e-learning platform of the IARS. Currently, we have about 58,000 subscribers globally, and about 65% of our users are from North America. Interestingly, number two is India. Actually, about 10% of our users are from India, and I'm hoping that speaking at meetings like this will increase that number even more. As I mentioned earlier, we have a global presence. We have members in about 130 countries, but as I said, predominantly North America for now. We're also creating content in Spanish so that we can have more users from Latin America. And also there's a big push to deliver content that's applicable in low and middle income countries. So our website was developed the new website was developed about 2.5, 3 years back. We have about 80,000 unique site visits every month. And as I mentioned, about 58,000 subscribers globally. I'm hoping to share my screen now so I can take you through the website. And you should be able to see the website now. So this is our homepage. And here we usually highlight using the banner on the top resources that are just being added. There's also a multiple choice question that's posted here every day. And then also a summary of the day. And we use the homepage to highlight content that's new on our website. So I'm just going to take you through all the different pages. So this just talks about what Open Anesthesia is, our vision and mission statement. That's me. And then we have a huge team, and I cannot emphasize this more. This is truly a team sport. There's so many people involved in this. We have close to 13 section editors who cover all the different subspecialties in anesthesia, pediatric medicine, and critical care. And we have close to like 20 or 25 associate editors also who work directly with our section editors. So this is a very big team of people involved in creating content for open anesthesia. And I'm just going to take you through all the different pages. So we have different types of content on open anesthesia. The first one is these seminars, which are essentially 5 to 7 page mini reviews of high yield topics. And I'm just going to take you through some examples. So if you click on this filter on the left side called summaries, and we have close to 464 summaries, and this number keeps increasing every week. I'm just going to give you an example. For example, this is a summary of the pharmacogenetics of analgesics written by a couple of my colleagues friends at Cincinnati Children's. The authors get credit for writing these. There's key points at the top, and then what you can see here is it's pretty comprehensive. It talks about, it has figures, it has tables, and it talks about the pharmacogenetics, all the different polymorphisms and such. And then there's usually a list of references at the end with links to PubMed and also other resources with links. So these are pretty comprehensive summaries. And then, and so we have 460 of these summaries. I'm just going to show you perhaps another one, anticoagulants. And just, again, similar thing, 5 to 7 page mini reviews, lots of tables, figures. They're meant to be clinically relevant topics, and they're pretty comprehensive. And also I want to highlight that all the content here is peer reviewed. And again, as I said, links at the bottom with PubMed references, etc. So that's the first type of content. And before I move on to the next one, I also want to highlight that you can go in and select that, okay, let's see, you want to only look at all the pediatric anesthesia summaries. You can filter that, and you can see here there's tons of topics from like the most basic stuff, like from anatomy and physiology of the infant airway to like Fontan circulation and not so common syndromes. So this is the first type of content. These are summaries. They're 5 to 7 page mini reviews. The next one is we also have podcasts. We have 3 different teams of recording podcasts. And also you can filter for these by specialty. We have a global health team that records podcasts. We have cardiac anesthesia team and a pediatric anesthesia team that also record these podcasts. These are typically interviews with experts in the field. They're usually about like 15 to 20 minutes max. And so these also are pretty popular, as most of our trainees are using these as they're, driving to work, riding to work, or on their commutes, they listen to these podcasts. The third type of content we have is videos. These are usually short videos. Again, you can filter by specialty, and so we have all different types of subspecialties covered in these videos, and also they're pretty high quality. Again, just to give you an example, if you want to look at POCUS videos, you can click on that link and it'll take you. We have our POCUS team records these POCUS case of the month. They usually will take a case and share some key points or takeaways from each of these different POCUS scenarios. So I encourage, if you haven't already, go and check this out. Similarly, we have something known as the PAINS curriculum, which stands for Pediatric Anesthesia Non-Technical Skills. This talks about non-clinical topics like medical education, QI, patient safety, communication, faculty development, etc. So we have different types of videos as well. Keys to the Cart is also something similar. These are 5-minute videos. Again, talks about different types of important keywords from the ABA content outline. The Society for Pediatric Pain Medicine also records these short 5-minute videos that are posted almost every month. So as you can see, we have tons of different types of videos on Open Anesthesia, close to like 460 of these as well, that are pretty high quality. It's all peer reviewed and purely educational. Finally, in the last few minutes, I want to share some of the collaborative opportunities that we have. These are external resources. These are not content that we develop. This is developed by our folks that we team up with. So the first example is APSF, the Anesthesia Patient Safety Foundation, records a podcast every month. So these are posted on the OpenAnesthesia site, and we have close to like 60 of these. Baby Blocks is the pediatric regional anesthesia website that also has different, so you can click on it, it'll take you directly to caudal block, and it talks about, and usually it's a description of the block, plus often there's a short video as well about how to do the blocks, etc. And so these are baby blocks, these are pediatric regional anesthesia blocks. The ICU one pages, these are one-page summaries of ICU topics. I'm just going to show you an example of what one of this is. For example, let's look at external ventricular drain. So this is all you need to know about EVDs in one page. These are super practical, high yield, great to study for exams or even like just discussions and teachings in the operating room. So I love using these one pages to just go over a topic with a trainee. And then another example of other external resources is, for example, we have simulation scenarios that are created by the Society for Obstetric Anesthesia and Perinatology. So if you want to run a simulation scenario on, say, cardiac arrest in an obstetric patient, it talks through all the things that you need to while setting up the simulation to like evaluations, etc. So also, again, super high yield. And then we also have other resources from like SNAC, Samba, SOCA, etc., also on the website. The WFSA is the World Federation Society of Anesthesia, so they have anesthesia tutorial of the week. They are also all posted on our website. We have a separate page of just all different cognitive aids. For example, you want to look up cognitive aids in pediatric anesthesia, I encourage you to check these out as well if you are interested in exploring this website. So as you can see, there's different types of educational content, summaries, videos, podcasts, online modules, cognitive aids. And so what we envision is a central repository of different types of educational content that's high quality and peer reviewed. So with that, I'll stop sharing my screen. I'll be happy to answer any questions later on. And I apologize, I'm speaking from an airport lounge, so I cannot control my background.
Thank you. Thank you, Deb. That was great. And thank you for being able to do this despite your travel plans, but excellent presentation. And we now move on to our next speaker, Dr. P.J. Saneesh. Dr. Saneesh, if you can put up your first slide, please. Deb, can you stop sharing and have Dr. Saneesh put up his first slide? He's been with us for many years. He's currently the registrar of Indian College of Anesthesiologists and is one of our key persons in making sure that these webinars are conducted every week. He's a consultant, senior consultant anesthesiologist and intensivist at the Anantapuri Hospital and Research Institute in Trivandrum. He has authored several books published in many index journals and has several academic ventures, including the YouTube channel, the Android apps, Anesthesia Tools. He runs the website for www.onlineanesthesiatools.com and also a webinar for an item called Campus and lectures in CMEs, conferences, and workshops. And like I said, he's a registrar and also peer reviewer for the Indian Journal of Anesthesiologists and for the Journal of Anesthesiology and Clinical Pharmacology. Time for you to take over, Dr. Saneesh.
Okay, so not a single Wednesday passed since the pandemic time, the 15th July 2020, when the ICA leadership started ICA webinars on Wednesday evenings. Team ICA is all about academics, and all the top leadership people are well accomplished in different academic arenas. You can imagine when this big league of leaders come together, we can make things possible. So Wednesday evenings were earmarked for webinars from ICA. Pandemic time witnessed so many webinars from different organizations. They were competing towards the weekend, and I think Radhakrishnan sir will agree. The leadership of ICA decided on a weekday, that is Wednesday. Most other organizations stopped their weekly sessions after a year or two, but ICA webinars are here to stay. And today we are proudly celebrating the 5th annual, and we are still continuing. So today is episode number 261, and I take this opportunity to thank the leadership for all the support, encouragement, and perseverance in continuing with this online academic program. I remember we conducted our first annual in 2021. I thought that was a great landmark. We had a virtual anchor hosting the program. We had lectures or address from eminent faculty. We had felicitations from the leadership. We also conducted an online
150
quiz
international units per liter,
nationwide, getting all the
INR
postgraduates
of
involved.
1.7, appetitive
And
1.9.
we had a prelim round and a
The
final round
sequenced
done
in,
on the first
ICA
annual day,
numbers.
and that was greatly appreciated. Then we had second annual of ICA webinars, where the stalwarts from global anesthesia organizations participated, and that was a top-notch, memorable annual day. Third anniversary, ICA webinars took a different topic on publications, research, remarkable research publications right from the press. So we could hear from the stalwarts in the area of research and publications. Fourth annual also witnessed the address by the stalwarts in anesthesia from across the globe, and all our top leadership and top academicians among the senior leadership of ICA contributed. The numbers are ticking. Now today is 5-year completion. The specialty of ICA webinars had been all our academic programs. The online webinars are all archived in our YouTube channel, ICA Academics, and the number of subscribers, views, watch time keeps going up and up. To go through the statistics, most of it is watched by age group of 25 to 34. That means youngsters are utilizing it. Yes, it's been a top academic resource. Topics, we used to go to different topics, anesthesia general topics, specialty related topics, including critical care. You can see obstetric anesthesia, onco anesthesia, cardiac anesthesia. I think Narayana Hridaylaya Kanchi sir has been organizing on all first Wednesdays. We are having cardiac and vascular anesthesia. We had sessions on echocardiography and whatnot. Whatever super specialty postgraduate or an enthusiast wants to know about cardiac anesthesia were dealt. We also had special notable sessions in pain management, regional anesthesia, pediatric anesthesia. We had case presentations, journal appraisals, participating postgraduates also. We had named it as PG Assembly. Now ICA has a different format of PG Assembly, an exam orientation program. That's a physical program conducted every year. We did give emphasis to research methodology to enhance the research culture among the youngsters or institutions in and around the nation. My sweet memories goes to different variety of topics. We had discussed beyond consciousness, the medico-legal dilemmas. We had a session dedicated to simulation, and we had online PG assembly where we got the youngsters, the postgraduate, the residents debating, presenting cases. We also had a PG conclave in 2022 where the postgraduates in India came up discussing their concerns, apprehensions, and their prospects were discussed, and eminent senior faculty took that opportunity to clarify them through this platform of ICA webinars. We did emphasize on quality and safety in operating room, as Radhakrishnan sir has mentioned. That is also an emphasis in the present day. We also had research topics like markers and genetics highlighted. We had a very interesting topic. I can see Mukul Kapoor sir. Sir actually moderated many sessions on less discussed topics, but they are very vital and they delivered key messages. We had special World Anesthesia Day sessions having renowned leaders from across the globe. And we also had sessions on palliative care and research. Recently, we had this webinar from idea to impact. So in a nutshell, I would summarize our ICA webinar efforts as the key success of the ICA leadership. We have a scientific committee approaching different faculty across the globe actually to deliver the contents. We have the support of youngsters. We call them as webinar hosts to help us conduct these sessions every Wednesday. ClearNet has been our digital partner since last 2.5, 3 years. Thanks to their services as well for the continuing success of ICA webinars. So here we are 261 and counting. I also like to mention about the ICA Olympiad 2025, which was a new venture we launched in 2025 to get into the postgraduate audience. The nationwide, all the postgraduate residents were coming under the umbrella of ICA Olympiad, where we did an online objective type examination. So this is one new way to open them to international exam pattern. We introduced them different objective type questions, which can be done through online. We serve them with preparatory classes. We did an online exam on April 6th, and we published the nationwide national ranking for each and every candidate who appeared for the exam. In the next national and international conference of ICA coming up in the end of August in Jodhpur, we'll be awarding the top winners with coveted cash prizes as well. So teamwork is the punchline. Again, with the success of ICA Olympiad, newer academic experience will enrich ICA academics further. I would like to mention that we have our presence in the Instagram, in the social media, Anaesthesia College _ICA, where we announce our programs and joining links for our ICA webinars. We were already there right from beginning in our Facebook account, facebook.com/ICA Academics. Again, coming out of online, I need to mention about the yearbook. I think yearbook 14 was released in the last conference, ICACon. The chief editors are Dr. Mukul Kapoor and Dr. Baljit, and the last time it was Dr. Gaurav Kaka. So we are looking forward to yearbook Anesthesiology 15, which will be released in the forthcoming ICACon 2025 in Jodhpur. ICA also runs Journal of Indian College of Anesthesiologists. We call it as JICA. And of course, all our updates and activities are published and available for the audience from our website, anesthesiacollege.in. With that, I take leave. Thank you for the wonderful opportunity. Wish you all happy academics, online academics, as we continue with the ICA webinars. Thank you for patient listening.
Thank you, Dr. Saneesh, and excellent review of all the activities that the ICA has been conducting over the last 5 years. Next speaker, if you can just put up your introductory slide, is Dr. P. Hemamalini, and she's the chief editor of our Echo library, and she will update us on the use of Echo and the library as it exists today. So Dr. Hemamalini, she's a consultant in cardiac anesthesia and intensive care at the Miyot International Hospitals in Chennai, and was one of the IACTA award winners named after me. Thank you, Dr. Malini, for being one of the experts. And she's the chief editor for the IACTA Echo Library and the associate Echo Library editor for 2021 through 2024. Welcome and take over, Dr. Palani.
Yes, sir. Very good evening to everyone. Today, I'm going to speak about something really close to my heart, the IACTA Eco Library. Briefly, I would be speaking about who we are, what we intend to do, or the purpose of IEL, how do we do it, enlisting the various activities and features of IEL, quickly take you on a virtual tour to IEL, finally wind up with metrics and our future plans. I assure you, this is going to be 10 to 13 minutes of absolute nostalgia for our regular viewers and would be a brief introduction to the newcomers. So my heartfelt thanks goes to both. One, the contributors without whom this would not have been possible. Second, obviously, the organizers for giving me this wonderful opportunity to present on this prestigious occasion of 5th anniversary of ICA webinars. IACTA Eco Library is basically a website. I would say we are a virtual academic endeavor of IACTA dedicated to echocardiography. The team behind IEL, as you see, all three are pioneers in echocardiography and do not need any introduction at all. My humble regards to all three of them. Echo Library is the brainchild of Dr. Rajesh Arya. Dr. Rajesh Arya, under the guidance of Professor Dr. Tempe, established as well as streamlined this website way back in 2016. My sense of gratitude to my mentor in echocardiography, Dr. Kumar cannot be expressed in words. His contributions to the field of echocardiography and to the IACTA Eco Library are innumerable, but I would like to say 3 points. First thing is opportunity to youngsters. During his tenure as editor, 4 of us, including me, had the opportunity to join and serve IEL as associate editor. Second one, the interesting echo of the month. One of the latest features of IEL, the idea and concept belongs to him. Third, he till date contributes to the activities of IEL, which includes the midweek quiz and the weekly echo. Meet my vibrant and enthusiastic team, my associate editors, Dr. Kaushik Jyotinath, Dr. Naresh Kumar, Dr. Shekhar Suman Saxena, Dr. Sucharita Das, and Dr. Adita. All are certified echocardiographers, passionate about echocardiography, and very interested and keen to pen down their thoughts. Echocardiography is a continuously evolving imaging modality, and we would like to focus more on the evolving trends of echocardiography at IEL. Our focus would be more on using like live or even Zoom mode or even the QLab multiplanar reconstructions, opening up and working on Q lobes, deformation and strain imaging, contrast echocardiography, fetal echocardiography. This one I've put up purposefully here. This one is a gastric ultrasound to draw your attention towards point of care ultrasound. Please do not confine this wonderful imaging modality to just one specialty, that is cardiology or cardiac surgery. As we see here, this is dissection of aorta. This can be seen in accidents, ER, and trauma units. This is reverse mecanal sign, which is suggestive of pulmonary embolism. As you all know, pulmonary embolism is common anytime in the perioperative period. This one is a bubble study, which is usually done when we evaluate any cryptogenic stroke, and we did find a PFO in this case. It is also done during evaluation of liver transplant recipients to rule out any pulmonary AV malformations. Here, echo guides cannulation of veno-venous ECMO, which is done for ARDS, which is very common in ICUs. So anyone from fellow to senior consultants across all specialties of anesthesia, can be general, cardiac, neuro, liver transplants, or ER physicians or critical care physicians. Obviously, we cannot miss the cardiologists and cardiothoracic surgeons. We need to have a working knowledge of echocardiography. Coming to the activities of IEL, we do 3 virtual activities. The first one or the earliest one to stream live was the weekly echo. The pattern is catching. It is in a question and answer format. And this goes live every month, second Saturday. We send email notifications to our registered users. I would say we have an archive of almost 205 manuscripts on the website. And I'm going to pull up a few articles from our archive. From knobology, or it's going to be physics of ultrasound, how do you acquire 2D, 3D evaluation and valvations, hemodynamic calculations, 3D echocardiography, or your QLabs you can find here. If you're someone searching for something interesting or unique in adult cardiac, we've got you. Mitral annular distension, thoracic aorta or cath lab interventions, aortic valve repairs, ECMOs, LVADs, and troubleshooting LVADs are available. I would say we have covered the basics as far as pediatric cardiac is concerned. This includes segmental analysis, AFBs, VFBs, AD septal defect, and tetralogy of Fallot. Or if you're someone who is looking for anything out of the way, we have got you as well. Evaluation of blind spots, epi-aortic, epicardial, basic, advanced fate, up until lung ultrasound are available. At this point, I would like to disclose the list is obviously not comprehensive, and my apologies if I have missed out any of the important articles from our archive. Now, the second activity, I would say it is the most popular activity of IEL is a midweek quiz. So as we see a question with echo media and 4 options to choose from, this goes live every Tuesday at 2 p.m. Once it goes live, an email notification is sent to the registered users. The user can either click on the link provided in the mail, or they can go directly to the website and participate in the quiz. The next day, Wednesday at 2 p.m., the answer with explanation along with the winner of the quiz will be provided. At present, we have a repository of almost 400 midweek quiz available on the website. And it is with extreme pride I say our questions always find a place in certifying and qualifying exams in echocardiography, as well as they are a part of various competitive quiz in echocardiography. Now, the third, the youngest, the latest one is Interesting Echo of the Month. This is mainly for people who are restless like me, like someone who want echo on the go. So we just confine the media clips to 3 to 5, a small abstract which explains or describes the media, and finally references with keywords. That is the third feature. They do exist in reality. So IACTA, along with Fate Group, conducts this prestigious Golden Fate contest every year during the IACTA PE workshop held at Narayana Hridayalaya, Bangalore. And I'm saying this here because the editor and the team of IEL coordinates this activity. Interesting clinical cases where echocardiography can be either transthoracic or transesophageal makes a difference in patient outcome are taken up. So the one selected for podium go to the Golden Fate, the other things go to interesting images or free papers. We do accept research papers in cardiovascular ultrasound as well under the RCVU category. Few things to be noted. Please note the upcoming GFC or the RCVU is scheduled on August 23rd, 2025. Submissions are still open. We do not stop with that. The award-winning presentations obviously find a place on the weekly echo of ACTA Echo Library. So having said so much, it would be incomplete if I do not take you a small quick tour of the website. So this is how our homepage looks like. Again, welcome all to ACTA Echo Library. So this is the recently published weekly echo and the recently published midweek quiz. I'm going to scroll down a few important features on our dashboard. So what we see here is the Echo Atlas drop down. You see published manuscripts. All the manuscripts which have been published up until date are available here. You can just click on whatever manuscript you want and then go through it. The next thing is going to be echo calculations, anything related to echo, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, or even hemodynamic calculations can be done on the website itself. For example, I'm going to quickly calculate cardiac output for you and just entering some of the parameters like diameter of the LVOT, VDI of LVOT. I'm just entering the random height 155 in centimeters, a hypothetical weight of 51 kg, heart rate of 76. It will just give you the cross-sectional area of LVOT, the stroke volume, cardiac output, and also index. So you can also find the formula which is being used by the software along with a small description. So that's about the calculations. We do have few reference guidelines updated on the website. For people who cannot remember any of the numbers like me, you can find the reference values, normal values, the abnormal values grading the severity of valve lesions, as well as normal values for prosthetic valves can be seen here. You can do submissions on the website itself. You can submit both the weekly echo as well as submit quiz on the website. The difference is you'll have to upload it in different manner. So if you have any queries, you are very well welcome to go through the guidelines for submission. Guidelines for the weekly echo as well as guidelines for this quiz submission are available here. As far as this bar is concerned, we have the links for after TE workshop conducted by Narayana Hridayalaya from 2018 to 2021. Never hesitate to contact us. And you can also search whatever you want on the website itself. For example, I'm just entering mitral stenosis here, and I'm just clicking the search button. It will give you all the relevant articles right away. And the last one, which some of them continuously ask me, is how do you go about with the quiz? The quiz can be found in the last, but you will just have to click on the previous to go through the previous ones. So that finishes the small virtual tour of After Eco Library. Needless to say, we are an academic endeavor of IACTA, so we can be found on the IACTA webpage itself. We are also indexed on Indian Association of Cardiothoracic Surgeons webpage. So you can find the link on the IACTS website as well. You can just get registered yourself over there, and also feel free to contact us over Gmail. Then this is a quick slide about the metrics. As I said, we have an archive of 205 manuscripts, a repository of 400 midweek quiz, and 2 IEM as of now. I would proudly say we have 4,890 members registered on our database, and almost 17,030 people have participated in the midweek quiz so far. 150 people were courteous enough to leave their comments about our weekly echo. The notification to the registered users are always through email. So this is just the breakup of emails which have been mailed from June 9 to July 9, 2025. Almost 29,100 mails have been sent regarding the midweek quiz and manuscripts. Almost 16,768 have opened, and this is only the number of people who have clicked on the link to participate. The others who opened on the website are not included. So these are some of the activities which we have planned in the future. Anything, suggestions, comments, criticisms, you're always welcome. Meanwhile, till we meet, happy echoing, happy learning, happy evening.
Thank you, Dr. Hemamalini. That was a superb review of the library, and I'm sure there'll be some questions. So let's move on now to the next speaker, Dr. Aruptatan Maiti, who will talk to us about critical care echocardiography training in India. If you can put up your first slide, please.
Yeah.
Dr. Maiti, as you know, is a well-known intensivist. He's a senior consultant of anesthesia and cardiothoracic society anesthesia at the Lancashire Cardiac Centre in UK, and he's done a fellowship with the Freeman Hospital in UK, and currently works at the Apollo Multi-Specialty Hospital in Kolkata. Welcome, Dr. Maiti. Please proceed.
Thank you very much, Dr. Belani. Good evening to everyone, and good morning to you. It's a privilege to talk today on the 5th anniversary, a milestone global webinar of the ICA. I'm going to just talk about perioperative and critical care echocardiography training in India. I have no conflict of interest, and why critical care echocardiography is important, because it gives real and immediate point of care evaluation of the cardiac function. Not only it differentiates different types of shock, but also guides us about the fluid and vasopressor therapy, and also detect life-threatening complications very early. And it supports any advanced ICU procedures for any mechanical devices, ECMOs, or any catheters. At the same time, it promotes a clinical autonomy by making quick evidence-based decision making. And by this, it avoids unnecessary intervention and unnecessary invasive monitoring. And to be honest, it has been a global standard of critical care now that critical care echocardiography is an integral part of the curriculum. So before coming to training in India, I have a couple of slides about the training in USA. Dr. Belani will probably be tell much better about what's going on, because I have never been trained in USA itself. So in USA, there is a fellowship-based training, and some centers offer fellowship in focus. There is some formal courses and certifications by CHEST, SCCM, and ASA. They offer structured CC training courses. Obviously, National Board of Echocardiography Certification CC exam started since 2019. Apart from that, there is some simulation-based education by using high-fidelity simulators. And because I'm associated with the American Society of Echocardiography and also took this NB exam, that's why I know that NB started the certification program on critical care from 2019. It's endorsed by American Society of Echocardiography, Society of Critical Care Medicine, ASA, and American College of Chest Physicians. And usually there is an MCQ exam and 4.5 hours long, followed by 150 TT or TE cases as a logbook needed for the certification. If you look at the curriculum, apart from the cardiac, if you look right down here, there's also lung ultrasound, lung and pleural ultrasound, followed by some vascular ultrasound and abdominal ultrasound have also been included into the curriculum. Coming to the training in the Europe, because I've been trained in Europe, and it's recognized as an essential for ICU physicians. And usually training can be national or pan-European training pathways, can be basic or can be advanced. Basic trainings of CCE can be like IVC assessment, LVRV function, or simple fluid status assessment at bedside, whereas advanced critical care echo includes some more valvular pathology, TE, diastolic function, and Doppler measurements. And these trainings are usually delivered by different hospitals, different societies with CME workshops or simulation labs. And ESICM has CCE level 1 and level 2 training and EDEC exam. ESCVI conducts exam for TT and TE, who usually read a theory exam for 4 hours, followed by a logbook of 125 cases to get certified or accredited by ESCVI. I worked in UK, and UK has got FUSIC and QSIC, and those are governed by different ultrasound governance structures. So coming to the perioperative and critical care echocardiography training in India, and till 2-3 years back, few society or few institutes were offering short workshops or fellowship or certification courses of the critical care echocardiography. Until 2-3 years back, the ICTS, in collaboration with Indian College of Anesthesiologists, ICA, developed the training module of certification or fellowship in perioperative and critical care echocardiography. Till last year, it was called as critical care echocardiography, but since this year, it will be named as perioperative and critical care echocardiography. So the ICTS and ICA, they confer the certificate or fellowship of perioperative and critical care echocardiography, known as FPCEE, and it is endorsed by Global Heart Care Foundation, Global Intensive Care, and International Society of Cardiac Ultrasound. So basically, it's a 12-month structured non-residential program guided by the qualified mentors, and to train physicians, TT, T, lung ultrasound, and ultrasound guided vascular access in critically ill patient. And this fellowship aims at anesthesiologists, critical care physicians, emergency medicine physicians, chest physicians, cardiac surgeons, intensivist surgical fellows who are offering ICU service. And the program includes weekly online tutorials covering theoretical and practical aspects of the cardiac imaging, some hemodynamic assessment, and also procedural guidance. And the hands-on training is done at the Trainage Institute or Hospital, supervised by a qualified mentor. And they require a logbook documentation of transthoracic echo 100 cases, T 50 cases, and lung ultrasound 50 cases. And that should be duly signed by a mentor. And that needs to be produced during the final practical exam. And that's a license to be eligible to be a candidate for FPCEE. And e-learning by weekly webinar usually happens on a Sunday morning breakfast session, usually a 30-40 minutes lecture followed by a 20-25 minutes discussion. As of now, ICA has conducted 192 webinar on this echocardiography and ultrasound. And at the same time, the candidates attend various workshops. It's mandatory to attend at least 3 workshops in 1 year to be eligible to be a candidate for FPCEE. And the workshop can be either based on echocardiography or POCUS or FOCUS. Apart from that, the simulation-based echo T training plus hands-on subject-based training of transthoracic echo, lung ultrasound, vascular access, gastric ultrasound, all are there. All are usually done in the IACTA T conference held in Bangalore and Delhi. Last year, 2024 December, with the leadership of Dr. Muralidhar Kanchi, we were able to publish the position statement on the use of ultrasound in intensive care in the Journal of Acute Care, and it was followed by the review article on use of T in intensive care unit and critical care echocardiography in intensive care unit. So all published in Journal of Acute Care in the same issue, volume 3. And this is a logbook sample of what the candidates needs to do for TTE. This is a sample, original sample from one of my students whom I mentor. You can see this left ventricular function followed by regional wall abnormality score. The RV function, all the valves are included, pericardium is included, pericardial effusion, and volume status needs to be seen. IVC, cardiac output, needs to be measured, LVOT diameter, ascending aorta, and at the end there is a summary of findings they need to write and what are the clinical recommendations, and each such report will be signed and stamped by the mentor. And this is a logbook sample of the TE. A TE logbook is quite robust and includes plenty of data, the same format we use for the TE exam also. And this is the format for the lung ultrasound, and it includes the lung sliding, B lines, consolidation, pleural effusion, and or any other findings, and left and right, and all the quadrants. At the end, they need to write a comment and conclusion duly signed by the candidate and the mentor and stamped. So the perioperative and critical care echocardiography fellowship, which I'm talking about, the syllabus is quite vast, encompasses the cardiac anatomy, neurology, ventricular assessment, valvular function, evaluation of the shock, different types of shocks, and advanced echo like dystology, mechanical devices, congenital cardiac disease, and ECMOs, and so on and so forth. At the end of 1 year curriculum, usually the final examination takes place in every December in Narayana in Bengaluru. And there is a MCQ theory 100 questions. Each question has 45 seconds to answer, and it also includes plenty of video clippings and need to assess the situation there. The successful candidates in theory, they proceed to the practical exam. All the candidates need to pass the theory and practical separately to get through the fellowship course certification. So in the practical exam, there are usually 4 tables. One is the simulation-based mannequin for TE, and TT has to be demonstrated on subject. Lung ultrasound has to be demonstrated on subject, and the viva voce and with a logbook. Usually 2 examiners per station, usually 8 external examiners will take the exam for the candidates successful for the practical exam. And the successful candidates are awarded certificate or fellowship of perioperative and critical care echocardiography. And so far, 30 candidates have been successful to obtain the FPCEE. And this is how the certificate looks like once they are successful. And that ends my slides. Thank you very much for patiently listening.
Thank you so much, Dr. Maiti. That was a great review of how to take the exam and how to pass. Our next speaker will talk about regional anesthesia. As you know, anesthesia now has advanced to the point that practically everybody gets a regional block. So this training is crucial and important, unlike when I was training, but now it's picked up so that every resident and fellow is properly trained. So our next speaker is Dr. Sumit Kalra, and he's going to provide us an update on this. He's currently a senior consultant at the Institute of Anesthesiology, Pain and Perioperative Medicine at Ganga Ram Hospital in Delhi, which I visited a couple of times. And he has received quite a few awards and appreciations and has published several chapters and has many publications in index journals and is a reviewer of the Journal of Neuroanesthesia and Critical Care. Thank you, Dr. Kalra, and now you can take over.
Thank you, sir, for the kind introduction. At the outset, I would like to thank Dr. Jayashree ma'am, Dr. M. Kanchi sir, Dr. B. Radhakrishnan sir, Dr. Baljit sir, and Dr. Kumar Belani for this opportunity. It's my humble pleasure to talk about the IDRA course, the flagship academic program at SGRH at Ganga Ram Hospital under the aegis of ICA. This initiative was initially launched as an offline program at Max Saket under the IPSA banner, the Indian Society Perioperative Sonography Association. I'm sorry, Interventional Perioperative Sonography Association, and it was started by Max Saket. However, it started in 2016, but then the COVID-19 pandemic hit and the logistical challenges, it made it difficult to continue the program in its current form. The initial form was only a 2-day workshop, which was held at Max Saket with the examination of IDRA. And there was no program which was held in 2021 because of the COVID-19 pandemic. Identifying its true potential, the Institute of Anesthesiology, Pain and Perioperative Medicine, Ganga Ram Hospital, under the visionary leadership of Dr. Jayashree Sood ma'am, took over its stewardship and made it a hybrid offline and online training program. This 14-month program now incorporates 8 weeks of webinar series followed by 2 days of hands-on workshop at Ganga Ram Hospital, New Delhi. The program strongly is aligned with our departmental goals of fostering a pain-free hospital, advancing academic engagement, and addressing practical limitations posed by the PCPNDT Act, which restricts the anesthesiologist, especially in the smaller setups, from gaining hands-on experience of ultrasound-guided regional anesthesia. Anyone who stops learning is old, whether at 20 or at 80. Anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. It's a famous quote by Henry Ford. And I'm putting it here because what stood out from the inclusive appeal in the program was the main highlight. And we had enthusiastic postgraduates to seasoned consultants to even HODs who registered for this course and have done successfully this course. This is the initial brochure which was launched, and for this year. This year is the 4th year of continuous running of this program successfully, and the brochure clearly mentions it's about we have all the eminent faculty who are practicing USG RA Pan India interactive workshops. There's and a standardized exit exams, and there are certain prerequisites for both parts, part 1 and part 2. I'll just come to that. Who can attend this workshop are the anesthesiologists, intensivists, emergency care physicians, and pain physicians. The prerequisites are the for the IDRA and part 1 and part 2, the person should have the enrolling delegate should be a life member of ICA. They should be pursuing a MD, DA, DNB degree for part 1. For part 2, they will have to be a qualified anesthesiologist. And basically, part 1 requires only attendance in one basic ultrasound workshop, whereas part 2 requires one basic and two advanced workshops. So the program is tailored in such a way that the delegate who joins in, he joins in and attends the webinar for the basic, followed by the workshop basic. And for the next year, when he comes, he will do the advanced workshop and the exit exams. So the exit exams for the part 1 are MCQ based, and for the part 2 are OSCE Viva Voce based exams with hands-on demonstration on volunteers. This is a kind of a segregation we have among the basic and the advanced tutorials. For example, for the lower limb, the basic will cover just the anatomy of the lumbar plexus and the femoral and the lateral femoral cutaneous nerve block, the aortic canal block, and the obturator nerve block, whereas the advanced will cover the lumbar plexus block, the Peng block, and the other rescue blocks. Similarly, the workshops are designed as basic workshops and as advanced workshops. Like, for example, in this case, the upper limb, the basic workshops has the supraclavicular, the interscalene, the axillary, and the infraclavicular blocks, whereas the advanced ones in the same upper limb will have rescue blocks of scanning radial muscular individual nerves in the arm and the forearm, and also the phrenic nerve sparing blocks. So this is how the evolution of the delegate happens from basic course to the advanced course and the workshop. This year in 2025, for the part 1, we had 110 delegates, and for the part 2, we had 90 delegates. These seats are limited because we have restraint for the space in the auditorium where they can sit and attend the master classes and the workshops. The course flow is webinars happen every Tuesday for part 1 and every Tuesday and Friday for part 2. The workshop, the part 1 will attend the basic and the advanced in the first year, and in the second year when they come, they will attend the master classes, the live demonstration from the OT, and the advanced workshops. And the examination for the part 1 are MCQ based, and for the part 2 are OSCE and Viva Voce. Here are a few glimpses of the IDRA 2025 course, which recently got concluded at Sir Ganga Ram Hospital last weekend. There was a flag hosting. All the IC president, Dr. Sood ma'am, attended it, and along with Dr. Baljit Singh sir from ICA and Dr. Pradeep Jain sir, the chairperson of the Institute of Anesthesiology at Sir Ganga Ram. The workshop was held at the Gripmer Academic Block. The function was inaugurated by the Padam Shri Dr. D.S. Rana sir, Chairman Sir Ganga Ram Trust Society, and other members of the Board of Management, and the President of ICA, Dr. Jayashree Sood ma'am, and Dr. Baljit Singh sir, CEO ICA. It was a highly interactive program with interactive master classes happening with live demonstration from the OT with the state-of-the-art technical team supporting us, where we could relay live blogs from the OT and answer all the queries of the delegates. Here are a few glimpses of the blogs being transmitted from the OT and the interaction. And even the workstations where we had the volunteers, the faculty to teacher ratio was very, very much in control. It was 1:2. There were 4 faculty for every station. You can see here in this photo, there are people wearing the red tag are the faculty, and the others are the yellow ones are the delegates. And even the faculty is using other multimedia gadgets to explain to their doubts. And this is how the OSCE and the MCQs are conducted, along with Vivas, which happen for the part 2. For the part 2, the candidates are asked to draw anatomical diagrams or even show some sono-anatomical structures on the volunteers with the machine. This is a very, very important slide, and it shows the state-wise delegate distribution across IDRA. And you can see there when candidates have been from all over the country, from Kanyakumari to Srinagar. And this is the designation-wise delegate list, which demarcates that across seniorities, we have had delegates who come and do this program from SR level to fellows to HOD level consultants also who sign up for this program because of its interactive and structured nature. These have been the successful candidates at Sir Ganga Ram Hospital since 2022 when the program has been taken over by us. And this year's results are still awaited. They'll be released by the end of this week. This all culminates into the convocation where this is a kind of a model certificate which is awarded at the convocation of the ICA, which happens at the National Conference of the ICA, ICACon. And these are the few glimpses of the last year national conference at KGMC Lucknow. We have this year the national conference at AIMS Jodhpur, and we have specially discussed with the organizers, and we have created a convocation package for the delegates who can come and just register for the package without registering for the conference and attend the convocation. This now I can just play a short video of the backend team and the efforts which goes behind creating such a national level program of such reputation. Thank you. For any queries, we can just send the email. Thank you so much for your patient listening. Thank you.
Thank you so much, Dr. Kalra, for a thorough overview of this regional anesthesia training program. We now move on to the last speaker who will update us on a contemporary education. Medical education begins at the medical student level, and it's good to hear even from the surgical viewpoint about how to take care of patients in the perioperative period. And I'm so glad that Dr. Lassiter has agreed to talk on this topic. She's an assistant professor and practicing pediatric surgeon at the University of Minnesota Medical School, and she obtained a medical degree from Duke University School of Medicine in Durham, North Carolina. She completed her general surgery residency at the Medical College of Georgia in Augusta. And during residency, she participated in grant-funded transitional science research fellowship. She has completed her clinical fellowship in pediatric surgery at the Nicholas Children's Hospital in Miami, Florida. And she is currently the surgery clerkship director for the University of Minnesota and serves on the clinical education and medical student education committees. And I interact with her in the operating room whenever we have cases together. So welcome, Dr. Lassiter. Over to you.
Thank you for that introduction. And I just want to thank the ICA for the opportunity to speak today, especially on such a momentous occasion, the anniversary of this webinar. It's truly a privilege to be here. I'm going to be talking about some contemporary approaches to training in perioperative patient care. I have no disclosures, except for the fact that I am not an anesthesiologist. As Dr. Belani mentioned, I'm a pediatric surgeon, but I am putting on my education cap at this time. As the surgery clerkship director, I oversee the surgical education for students who are doing their mandatory rotation in surgery in their third year in their MD program. So what do I mean by training? Traditionally, we talk about postgraduate residency and fellowship training, but broadly, this can also apply to medical school and has a continuum onto continuing professional development for practicing anesthesiologists and surgeons. My focus, again, is going to be on medical student education, given my role. Unfortunately, there is an alignment in approaches to education around this topic in the medical school as well as residency training programs. There are certain trends that apply to both, one of which is competency-based medical education. So we'll get into that a little bit further, but EPAs more focus on how students do certain things, if they are capable of certain skills, as opposed to whether they possess certain knowledge. There's also more focus on team-based and interprofessional learning, more use of simulation, and lastly, technology-enhanced practice and learning. There are several apps, as well as virtual and augmented reality tools, and we'll go through some of these in a bit more detail. First, starting with entrustable professional activities, I started in my role as the surgery clerkship director about 2.5 years ago. And I was immediately thrust into this idea of EPAs and entrustable professional activities. And so I took it upon myself to get a better understanding, because I understand they're coming for several specialties. We certainly use them in our surgery residency training as well. We were one of the pilot sites for the national EPA program in surgery, as well as for the medical student EPAs. An EPA, there are two different definitions here, can be thought of sort of as a unit of observable measure. So taking multiple milestones and coalescing them into one demonstrable activity. And I'm going to show you what those exactly are. But the idea is that the trainee or student can perform certain activities at the end of their medical education or training program, and be trusted to do so well. So there are 13 EPAs that are released by the AAMC or AAMC, the American Association for Medical Colleges. And those are, we use all of the EPAs at the University of Minnesota. I think we were an early adopter of the idea of EPAs. And I think we were unique still in being one of the only medical schools that uses all of them. It's sort of been a process of figuring out how to best utilize EPAs and now actually apply them to student progression, and deciding if they can progress to the next level or onto residency based on whether they are entrustable with these activities. We don't need to go into all of them in detail, but I just want to call out a few of them that are more specific to surgery and anesthesia, where there's a lot of overlap. So EPA 1, gathering a history, performing a physical exam, entering orders, interpreting common tests, recognizing a patient requiring urgent or emergent care, and initiating evaluation and management. You can imagine a patient who needs an airway emergently. There's a lot of crossover there with anesthesia and surgery. Specifically, when we talk about procedures that are specific to a physician, the AAMC names some examples like performing CPR, bag mask ventilation, sterile technique, inserting an IV, replacing a Foley catheter. And so a lot of things that do occur in the perioperative setting. So there was a natural, move on to the next slide. You can see a natural partnership developing there between surgery and anesthesia to accomplish these EPAs and more competency-based education. For the medical student EPAs that I just listed, these are the levels of intrustability. They go from observation only up to indirect supervision. We do number those, so our observation being number 1, indirect supervision with just double checking the key elements is level 5. We typically want a student to achieve level 4 or 5 in order to move on to their residency training. So it just so happened with all of the EPAs being adopted and trying to figure out how to best utilize those a couple years ago, it came at a time of immense curricular change within our medical school. And I think that's been a trend throughout other medical schools in the country. A lot of them are kind of revisiting how we conduct medical education. And so there was an opportunity to change the way that we structured the surgery clerkship. At the time, it was a 4-week experience. There are many reasons why it made sense to combine the anesthesia clerkship, which is an optional elective clerkship, or was up to about 2 months ago, for obvious reasons that we've discussed, but also because not only surgery and anesthesia residency programs, but also other specialties were looking for students to have had some exposure to anesthesia and more procedural competence before coming into residency. So we decided to partner together and change the design of the clerkship from 4 weeks of general surgery to now it's an 8-week clerkship. ILT listed there as independent learning time. So the students have a number of modules and other activities that they can complete, but those are sort of staggered throughout. Each student has an individualized schedule, and they have a week of anesthesiology and most instances on the clerkship. Also a subspecialty or outpatient experience that's 2 weeks, and then their traditional 4 weeks of general surgery. In doing this, we wanted to be meaningful or take a purposeful, intentional approach to how we did this, rather than making this just an additional week of anesthesiology and add-on, if you will. We wanted this to be more of an interdisciplinary approach. So with that, we incorporated anesthesiology into the existing framework of the clerkship, but also added several activities that were beneficial to make sure the students also got the general knowledge that they needed in order to pass the elective portion of what had been an elective clerkship in anesthesiology. One of those things is that we found that there are quite a number of students who are interested in anesthesiology. I think increasing the exposure increases the number of people who want to go into it. They might not have ever considered it as a career. So we've given certain students who have expressed an interest an option to do 2 weeks of anesthesiology instead of 2 weeks of a subspecialty or outpatient experience, subspecialty in surgery, that is. And said they'll do 2 weeks of anesthesiology. We also have a skills lab, and that's more in our simulation center on the second day of the clerkship, which we've added an additional station to go over airway management. There are 2 specific online modules that are relevant to perioperative and postoperative care that we also use. And this is from the American College of Surgeons. It's a curriculum that's free to anyone. You just have to have an account that you create with the American College of Surgeons to access this material. We also have a case-based lecture, so more of a flipped classroom approach that is specific to perioperative management. The last thing that I put in there is that I didn't really think about it as much until I went to put together this talk, was the idea of this interprofessional team learning activity that's also a new addition to the 8-week clerkship. And that comes more from the medical school working with other disciplines, who are our nursing students, some of our therapy students as well. But in general, there's an acknowledgement that we all work together across disciplines rather than just sometimes we can be in our own silos of training, but I think team activities are important to surgery and anesthesia. This is just an example of a setup for one of our simulations. We have our mannequins, we go over airway management. Again, the bag mask ventilation is a skill that really any graduating medical student should have. And then moving along to then the next component or trend is the multitude of apps. There seems to be an app for everything. But one of the apps that we utilize in surgery is to look at surgical risk using the American College of Surgeons National Surgical Quality Improvement, or NSQIP for short, risk calculator. This is also freely available. You can go online and basically plug in different characteristics about your patient, what surgery they're having, and it gives you an idea about what their risk is. I seem to have put in a number of high risk factors for this patient, so they're above average risk for undergoing a laparoscopic cholecystectomy. Again, many of these are things that are going to be evaluated by the surgical team when they're doing their clinic visit, or if it's not elective, seeing the patient in the emergency room. But also, again, you can see where there's a lot of overlap with our anesthesiology colleagues who are doing the same. It can also be used as a tool for our students who are learning to identify those risks. And this was an interesting app that I also found looking at ERAS protocols, or enhanced recovery after surgery. I created an app for patients who were undergoing colorectal and or gynecological oncology surgery, and they queried patients as well as clinicians to see what they thought about it. And the number of the patients thought it was very helpful in preparing them for surgeries, or what to expect, give them specific checklists and education modules beforehand, what to expect post-operative day 1, 2, etc. The clinicians were asked specifically what they thought about the app as far as its ability to navigate through it, and they thought that it would be easier to navigate, especially for some older patients who may not be as familiar with technology. They thought that they anticipated that it would decrease the amount of calls that they would get from patients with questions. The next thing, I'll just add this here. I think that this could be its own separate talk, but future directions and the use of artificial intelligence in both curriculum development, but also in organizing data. So we have big data, these large databases. The NSQIP calculator that I showed is really based off of those sort of large population level data in order to risk stratify. And AI will inevitably be incorporated into that, and using the AI then to help with clinical decision support. I put this picture specifically, this picture that AI or ChatGPT put together. And if you look at it very closely, you would wonder what this person is doing up at the head of the bed. What are they really doing with that tubing? And whether or not it's actually useful at all. But I think you also look at the heart rate for the patient. I think it's 18, which would be highly problematic. So I think understanding how to use this AI meaningfully and in a way that's trustworthy to rule out to patients and trainees is something that we'll be navigating in the years to come. So I will just leave with this thought that training in perioperative care is really enhanced by an interdisciplinary and longitudinal approach, starting with medical students. The increased use of technology and AI in both training and practice is really inevitable. And I thank you all for your attention and time. I welcome any questions as we move to panel discussion.
Thank you, Dr. Lassiter. Good to have a surgeon be on this program so we can learn from the other side also. I now open it up for questions, and invite the panelists. One thing I'd like to request is Dr. Chatterjee is about to board his flight, so we should address questions to him right away.
One question from me, Muralidhar here. Can we contribute to this open anesthesia portal? If yes, what should be the type of the articles and what should be mode of submission?
I'll be happy to share the template for our summaries, which are probably the easiest way to contribute. It's a standard template. These, as I said, these are 5 to 7 page mini reviews of high yield topics. So my email address is, I'll share it in the chat box. It's dchatterjee@iars.org. And that'll probably be the easiest way to contribute topics, and we can go from there.
Thank you. How to become a member of this open anesthesia?
So if you go to our website, so OpenAnesthesia.org, there's a way to sign in and register. It's free. It's open access. Just enter some information about your demographics, etc. And it's free and open access. But yeah, it's on our website.
Thank you. Thank you.
You're welcome.
If the younger contributors contribute and it gets accepted on open anesthesia, is that considered as material relevant for promotion for the younger faculty?
Absolutely. So our summaries are, we allow a maximum of 2 authors per summary. And this is it's considered online peer-reviewed educational material, and more universities, at least here in the United States, are recognizing this kind of non-traditional, non-PubMed ID publications. And so it's increasingly being recognized as scholarly material for our education portfolios. And so, yes, it is definitely a low-hanging fruit, and it also allows an opportunity for faculty to mentor trainees, junior faculty, etc. So, yes, it's definitely an option, and it's considered peer-reviewed.
Dr. Mukul, Kapoor, and Dr. Baljit, any more questions before he boards?
No, I think it's a wonderful initiative, and we haven't experienced it. Probably we should experience it, work on, I think maybe get a login multiple times and get an idea. Then we'll be a little more aware of it, and probably then we can do better. We can then communicate with Dr. Debnath Chatterjee after that, because we haven't used it. So I don't think we should ask him some difficult questions and look like a fool when especially since he's running this. And I've heard the name Open Anesthesia, but let me tell you, I've never tried to log into it and looked into it. Thank you, Dr. Debnath. I'm sure we could log in and we'll look into it. Thank you.
Absolutely. Thank you.
Okay, if there are no more questions for Dr. Chatterjee, we can move on to any other questions. Anybody have any questions? Dr. Baljit, yes?
Question. Whatever query I had, Dr. Muralidhar has already asked. I think we'll go to the website, and in case there are any queries, we certainly can get back to Dr. Chatterjee. For the moment, I think he can take his flight.
Deb, any of our webinars that we've been doing, can those be incorporated into the open anesthesia, or something can be given so that they can be reflected to go there?
So I think we can definitely talk about this offline. We try to push for content that's shorter in duration, usually 5 to 10-minute videos, etc. And so I'll definitely be that can be shared on Open Anesthesia.
Thank you. So thank you, and have a safe flight and stay in touch.
Thank you, Dr. Debnath, for being
Thank you again for this.
Thank you so much. We really appreciate your presence and we're grateful. Thank you so much. Thank you.
I'm sorry I have to leave early. Thank you.
Sure. Any other questions for any of the other speakers? Dr. Hemamalini, can non-ICA members contribute to the echo library? And are the echoes peer-reviewed before they are actually published?
Yes, anyone is, you're always welcome to contributions, more so from the non-cardiac, and you're always welcome to critical care echocardiographies. All the submissions are subject to a peer review, both the external reviewers, internal reviewers. Finally, it is being verified by the chairman, sent to the authors, back to the query replies. Once they reply, the final one gets uploaded on the website. You are always welcome for submissions. We would focus more on TTE and focus as of now.
Excellent. That's good to know because, once they become public, we want to make sure that they have been peer-reviewed and accurate. So that's great that y'all are doing that. Any more questions for her? Doctors Kapoor and Doctors Baljit Singh.
Belani sir, I would like to say that, it's in my mind that I'm going to, for the Annals of Cardiac Anesthesia, I may soon be putting links of the IACTA Eco Library. And then maybe we put some QR codes and or the links or the web links, and then people can access through the Annals of Cardiac Anesthesia, the Eco Library also, and see some important videos. That's in my wish list. I hope to do it in the near future.
Thank you.
That's a great idea. Yes, yes.
Okay.
Very happy news to us, sir, from Eco Library.
Can you repeat the question or comment, Hema?
Yama, please say that again, what you said last.
No, sir, I said it's a very happy news to hear from Team IAL. Whatever Mukul sir said, we are actually very much excited.
Okay, that's great.
Great.
Dr. Maiti, does critical care training, echo training in India, does it begin with the medical students or do they have to be in the PG programs before they start learning about it?
I think at this moment, they have to be in PG programs, not for the medical students. I'm not exactly sure whether the medical students' curriculum have anything related to echocardiography, but for the postgraduate students, anesthesia and medicine, they have echocardiography, transthoracic basic views, transesophageal echo basic views, and more this focus and focus, those things getting incorporated in their curriculum. At this moment, only the postgraduate students who have passed the MBBS. The MBBS, post-MBBS candidates we can offer this certification course of critical care echocardiography who are working in ICU, and those who are postgraduates, they can apply for the fellowship of the critical care echocardiography currently.
Thank you. So, Dr. Lassiter, do our medical students get training in echo for like POCUS, point of care ultrasound, things like that before they become residents?
Well, I don't think it's mandatory. So there are options to take a course in ultrasound, and one of the curricular changes that we made was the fourth year of medical school is now different as well. It's called specialty specific transition. And there are several different tracks that students can go on based on their identified specialty. So I'm sure there's a specific track to anesthesiology. I help with development of the one for surgery. But in addition to required courses, there are suggested courses. And I'm pretty sure we put the POCUS course on the list of recommended courses for the students, that in radiology. But specific to echocardiography, I don't know. I have been taking notes, however, about all the resources that are available here that we may be able to incorporate into our clerkship.
Okay, thank you. Dr. Saneesh, how do people find out that these webinars are available on YouTube? I know you mentioned Instagram as a social media approach. Is there anything else that people can be made aware of so that they can access these highly developed, highly effort-oriented videos that we put together, over 260, I think, right?
Yes,
So how
yes.
do people find out about those?
Actually, nowadays, every week our delegates registration link change. So we need to announce it through email. So we regularly send email communication to all the ICA members. Plus in our social media platform, which we are announcing. So even non-members can get to our Instagram page, Facebook page, and get the registration link. And I think now our flyers are being circulated to many of the WhatsApp groups, the academic WhatsApp groups. So people are getting access, but definitely we few days after our webinar, the recorded videos are uploaded in the Anaesthesia ICA Academics YouTube channel. So nowadays, most of the offline viewing, like live viewership, more than live viewership, the YouTube viewership is going up. Especially people are utilizing it for their academic purposes. So we are happy that our subscriber level, the viewership duration, everything goes up this time.
Good. So the thing is, it might be good one of the suggestions is that to have a list of all the webinars that have been put out and attach a link to the YouTube for each of them so that if somebody wants to look at one particular one, they can quickly click on it and go to it. So this could be something that has been suggested.
Yes, yes. I agree with that. We should have an index where
Right.
if I want to see coronary circulation, I should be able to get it straight away rather than going to the entire list.
Okay.
Correct.
So that's something for you to do, Dr. Saneesh. Now, Dr. Kalra, there was a great 8 week of training. I think it was 8 weeks. Are you the first one in India to do this regional anesthesia training program with a certificate?
So, actually, this kind of a hybrid model is the first one in India, where for the 8 weeks we do this online teaching program, and still after that the workshops happen for 2 days, and for the whole year we are in touch with the students and the delegates via WhatsApp groups and emails, and they are told to maintain logbooks. We have had very highly interactive WhatsApp groups where people have posted their queries while doing a blog, and even one of my colleagues and one of my seniors used to do video calls to them and guide them in putting that blog. So ours has been a very highly interactive way of teaching. I think this use of gadgets has been highly utilized, and since it is a distance learning program with 8 weeks of hybrid model, so people don't hesitate to sign up for it. They can spend that one evening away from the family, 6 p.m. to 8 p.m. and attend the webinar. And because they will only have to come physically for 2 days to Ganga Ram. Other time, they can just be in touch with us. So we have had very good responses. And if you will come over in Jodhpur, I can show you the logbooks. So you will be surprised by the quality of logbooks they have made, really. They are such beautiful logbooks people have made of their blogs with photographs, with digital imprints of the ultrasound images. So we have had very good dedicated candidates also.
Excellent.
Excellent.
Dr. Lassiter, you think the surgery candidates, residents would be also interested in learning regional
So
anesthesia?
they are highly I'm so sorry to interrupt you. Please continue.
Yeah.
Please complete your question.
Yeah, because sometimes they may have to go to places where they may have to do their own regional blocks. And Dr. Kalra said there were non-anesthesia people also that took the course. So is
So
that true for both India as well as USA?
Well, I'm not aware of that. I did get some training in blocks. I think it's been shown that they're more effective when they're ultrasound guided, and that may be a skill set that we usually defer to our anesthesiologists who have regional pain training. But I suspect that our residents would be interested in that if they given the opportunity. I certainly would have liked it when I was training.
So Dr. Kalra, what's happening in India? You said there was a range of majority were anesthesia, of course, but you also had other people. So were there any surgeons or I'm sure the ER people were there because they sometimes have to block, patients in the ED, as you call it.
We have had a few of the ER physicians, sir, who did the course, but as far as surgeons are concerned, the bunch of residents in surgery we have at Ganga Ram are very, very enthusiastic, and they do keep a close eye when we are doing the blocks, and a few of them have actually learned it very, very nicely also. And it has helped our patients a lot. Why? Because they are now so well used to putting IV lines with ultrasound. Now they can see the nerve, they can also see the vein. So it has, as a collateral benefit, it has helped our patients. So even the first year surgery can use ultrasound and put a IV line. So that is one benefit it has, given up our hospital.
Excellent. So Dr. Lassiter, is there anything in education that may be relevant to the current generation of trainees? What do they like? What do they dislike? And also, one thing you said is to work as a team activity. Do you have any suggestions how to train this new generation of trainees?
Well, that's such a broad question. I think yes, there are things that they like and don't like. I think feedback seems to be really important, and that's something that I didn't get into as much. There are several apps directed at feedback in the form of EPAs and other forms of coaching. I think that our trainees really crave feedback. I think they sometimes need you to say explicitly that we are giving feedback now, because sometimes I think they don't appreciate that what you're telling them, that sort of subtlety of what you're directing them to do is true feedback. So I would say that's a big thing that they crave. I think they're also more facile with AI tools, and I think that's something that we as the trainers or the instructors need to be aware of, because I think they can sometimes be a crutch, and it takes somebody who understands when the AI model is hallucinating or otherwise giving bad information. I think there's a learning curve to be able to use it effectively, and even though they're more facile and they understand the different apps, I just learned of a new one the other day. It'll be interesting to see how those are used in the actual clinical care and education in the coming years.
Thank you. I think let's see if any other comments. Yes, Dr. Kanchi.
I have one question for Dr. Lassiter. It's a sort of funny question, if you don't mind. In the surgical training, when they are undergoing anesthesiology rotation, were there any instances where the surgical trainee liked anesthesia so much that he changed his specialty?
Well, so I specifically work with the medical students, so they're
Right,
sort
right.
of not declared yet that that's what they're interested in doing, but we have seen a number of students already, because we've only been doing this new model for the last 2.5 months, but a number of students who are pleasantly surprised about how much they like
Yes.
procedural specialties, surgery, and anesthesiology. So I think it's we've had to expand to additional sites just to take on a greater number of students who want to do the 2 weeks.
Thank you. Thank you for that response. Thank you so much.
In my experience over the last so many years, I've seen it both ways.
Right.
In trainees switch from surgery to anesthesia and vice versa. So it's both ways.
Reciprocally.
And then the other thing was, I know it's probably different in India, but the surgery residents, I mean, students, they have an elective in anesthesia, but that has nothing to do with the duration of surgery training, does it? I mean, I think it's an elective, so it doesn't affect the duration. Is that correct?
So it doesn't affect the core component of the clerkship, which is still the 4 weeks of general surgery, but it will shorten their time that they spend on a subspecialty or clinic. So that they have 2 weeks of something else. So they can be urology or ENT or neurosurgery clinic. So they would do a shorter duration of that in order to do an additional week of anesthesiology.
Is anesthesia required now for medical students?
Almost. So it is a part of the other components, the modules, the lecture, that is all required and incorporated into the surgical court clerkship, but not all of our sites, most of them. But we still have a couple of our 11 sites that don't have a week of anesthesiology, but I'm hopeful that the students will be quite vocal about wanting more anesthesia exposure, and that will change next year.
We have noticed an increase in anesthesia interest since the anesthesia rotation has become almost routinely available now, but it's filled up to the point where we can't offer additional spots for it. So it's become a challenge.
That's great.
Okay. Yeah. I think.
Can I add, Dr. Belani?
Yes,
Yes.
yes.
Yes, so very
Yeah.
true. So also in our country, at least I can vouch for our hospital, the interns, the people, the students doing internship have a compulsory rotation in anesthesia. And I've had students, because we have the full training program for them for the 2 weeks that they spend with us. And I've had students who have come to me many years later and they've said, ma'am, we've joined the anesthesia specialty because of the anesthesia training during our internship. So I think that plays a lot of role and we are really proud of it.
Excellent. Thank you.
So may I add,
Doctor,
may
yeah.
I add what ma'am was just mentioning? Actually, there's been a change in the training program in the medical school in India also. So now during in the 4th year and the 5th year, there is what is called as competency-based education, and lots of anesthesia topics have been incorporated in that. And anesthesia postings have been increased in the medical schools now, MBBS students also. So hopefully, people are more aware now of about anesthesia, and we are going to get better people probably in anesthesia in the future. Because when I joined anesthesia, I remember I had no exposure to anesthesia during my medical school days, and it was only later that I learned about anesthesia. So now things are better and people are more aware. Since I work in a place where I also do teaching in undergraduate areas also, and I'm telling you, the interest the undergraduate students, the medical school students show in anesthesia is tremendous. Thank you.
Yeah, that's very true, because we have an exchange program with St. John's and Narayana Hridayalaya in Bangalore, and anesthesia is not typically chosen by medical students in Bangalore or in India because the students don't get to do much when they go there. But now that has changed, and I think that change might bring about the election of anesthesia as one of the things that they want to rotate in during the overseas elective. So that's good to know.
Right.
I think we've pretty much come close to the end.
Yes,
So
yes.
Drs. Kapoor and Dr. Baljit Singh, anything else before I hand it over back to Dr. Kanchi?
So I would like to add something, as a corollary of what was mentioned by Sumit in the end about intravenous access. I think it's time that as a college, we should start not a webinar, but a course in ultrasound guided intravenous cannulations. Because this is something difficult, even anesthesiologists can't do it well because they're not trained in it. It is time where we started a course in this, and a certificate course maybe. And really, I think it'll reap a lot of dividends. We face regularly, even though we are all supposed to be experts in intravenous cannulations, at times we also struggle, especially in babies. And so I think it's time that we also start an educational course in ultrasound guided intravenous cannulations.
Sounds like a great idea.
Yeah, you can take the lead, Mukul.
Yes, ma'am.
Okay,
Yes.
thank you. And now I'm back to Dr. Muralidhar, and thank you to all the speakers for doing a
Thank
super
you.
job and making this program enlightening.
It's a grand program. Thank you so much. I'm really delighted and enjoyed it thoroughly from beginning to the end. And it's my duty now to request Dr. Baljit Singh to say his comments and then say a vote of thanks on behalf of the leadership in ICA.
Thank you so much, Dr. Murali. Well, it's a great feeling to be part of this webinar. We're celebrating 5th anniversary. When we started it, it was basically the brainchild of Dr. B. Radhakrishnan and Dr. Jayashree Sood both. When we started way back in July 15th, 2020, we didn't have any targets, no goals to achieve. We just started. As I said, you take one step and the next step shows up. And that's how the journey continued. And it's wonderful to have continued without a break for 5 years. And next week we'll be starting on the 6th year, and it's a great feeling. With regard to today's program, I first of all would like to thank the overseas participants, particularly Dr. Lassiter and Dr. Chatterjee, who has already, and it's as Dr. Belani also pointed out, great to see a surgeon among anesthesiologists, and I hope this kind of coordination happens in future too. Further, I would like to thank the speakers, Dr. Saneesh PJ from Trivandrum, as to how he has been conducting ICA webinars in the Olympiad. He gave an overview of all the activities. Dr. Hemamalini, with regard to eco library that she is managing, and then Dr. Aruptatan with regard to critical care echocardiography, and Dr. Sumit Kalra spoke in detail with regard to Indian diploma of regional anesthesia, which is very, very popular. I was there to see this just 2-3 days back. It's a wonderful program, and very enthusiastic participants who were there.
Thank you, sir.
And the discussion which Dr. Kumar Belani conducted after all the presentations was very interactive, and I think it brought out whatever queries which were there in our minds. So before we end, I would like to thank all the speakers once again and look forward to having them on board on ICA platform in future as well. And before we sign out, I would like to thank Ms. Shirasi on behalf of Glenard for putting it up online. And till we meet next week again, stay happy and stay healthy. Good night to everyone, and to our overseas friends. Bye-bye.
Thank you. Thank
Good
you.
night. Thank you.
Thank you,
Thank
sir.
you.
Thank you, sir. Thank you,
so
ma'am.
much.
Thank you. Thank you,
Thank
dear.
you. Good night.
Virtual
Thank you.
cake and the dinner, following dinner. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Thank you and good night.
Good night,
Thank
sir.
you.
Good night to all of you.
Thank you, sir.
Thank you for arranging the cake.